So this morning, I'll be sharing a story about a complex patient that we have managed in a community. And in line with Singapore Patient Conference, we will also be sharing the perspective of the patient, the family, and some photos in this presentation. I just want to mention that consent has been taken for the use in this presentation. So our story starts now. This is Madam Lim. She's a 59-year-old lady. She's married with 3 children, and she lives with her husband, Mr. Raymond Tan, and 2 helpers. Of significance, she has a history of multi-system atrophy with predominant cerebellar ataxia subtype, commonly known as MSAC, and she has been followed up with neurology over here since 2013. At this point in time, she has impaired mobility, as well as she requires some assistance with regards to her ADLs. I asked Raymond Tan, Mr. Raymond Tan, how he felt Madam Lim was coping with this condition, given the fact that she's quite young, she's just 59 years old, yet she is quite functionally impaired, and this is what he said. Muihia's gentle ways belies a steely and stubborn character. She always feels she's blessed and rarely feels sorry for herself. While she doesn't understand why she's afflicted with such a rare and untreatable condition, she puts her faith in God and family. So there was a turn of events earlier this year on the 10th of March 2018. Madam Lim started feeling unwell for about a day. She had more secretions and saliva, and she was drowsy after lunch at about 1 p.m. The family could not rouse her until about 7 p.m., and Mr. Raymond Tan actually called Madam Lim's brother, who is actually a medical doctor, who advised him to send the patient to the hospital. On arrival at ED, Madam Lim was found to be pulseless, and she had no spontaneous breathing. She was resuscitated and intubated, and the impression then was a cardiorespiratory collapse due to airway obstruction from vocal cord palsy as well as secretions. So you can see this must be quite a harrowing episode for Madam Lim as well as the family, and this is what Mr. Raymond Tan's thoughts were. He said that he was alarmed and extremely worried, especially when we don't know what's happening to her. Had difficulty waking her up and was told she had a heart episode upon arrival at A&E. Wondering if I had sent her earlier, we may have prevented the heart attack. So what happened to Madam Lim after that was she stayed for quite a while in the hospital. She had a tracheostomy inserted. She had multiple complications during the stay: infections, NSTEMIs, transaminitis, BIGIT, AKI, you name it, she had it. She stayed for 2 months, actually more than 2 months, and she was eventually discharged on the 25th of May. And at this point in time, she was bed-bound, ADL dependent, and she went home with a tracheostomy, an IDC, and an NG tube. I just want you to look at this HITS history at what happened to Madam Lim actually right after she was admitted. And in line with what Prof. Leong had said earlier, this is what, as a mahjong, if you are the mahjong player, you would say this is a hospital lose. So she was discharged on the 25th of May 2018. 10 hours later, she was admitted for catheter-associated UTI. Very shortly after, she stayed only 18 hours out of the hospital, and she was readmitted again for respiratory tract infection. The next admission, she managed to stay out for just a slightly longer period of time, 3 days, and she was admitted again for lower respiratory tract infection. So you can see that she was discharged at this point in time on the 21st of June. The community health team came in 5 days after, on the 26th of June 2018. This was a first home visit done by our physician as well as the nurse clinician. And I just briefly put up some of the things that were found during this home visit. So one of the things that were picked up was actually the patient had been having several episodes of low-grade fever. The caregivers were not confident in the NG tube feeding, given the fact that she had been in hospital for 2 months, and most of these were being done by the hospital staff, the nurses in the hospital. She was also found to have 2 sacral sores that were stage 2, but they have been stable since discharge. And also, Madam Lim had only managed to sit up once after discharge, and she had not showered at all in the 5 days after discharge, as the caregivers were not comfortable with doing so, and they said that they were not taught how to do so during the inpatient stay. So really, for a community health team to work and for this sort of transitional care model to work, what we really need to do is we need to empower the families and the caregivers to care for the patients at home. And a lot of this has to do with crisis management. So what to do when there is a slight change in the conditions of the patients. In this case, mainly fever. She had recurrent episodes of fever. And also what to do to care for the patient at home. So in Madam Lim's case, NG tube, IDC, as well as a tracheostomy, and the fact that now she is fully dependent in her ADLs and also bed-bound. So what we did at this point in time was we gave some crisis management advice. We gave her some thresholds, gave the family some thresholds on how to escalate when she has fever. So a fever of above a certain threshold, you need to do this. Above another threshold, you need to do this. That was very helpful for them. We also provided CGT for the NG tube feeding, as well as how to troubleshoot if there are issues. Dressing CGT as well as prevention advice was given for the sacral source, and we were also referred to our CHT occupational therapist for transfer, sitting out, and showering CGT. So this next chart, I won't go through the entire thing, but I just want to show you these are the various time points where our team had to make contact with the family. What you can see is it is very frequent. It's every few days, sometimes just separated by a day, 1st July, 2nd July, 13th July, 14th July. And multiple issues were actually brought up. One of them being care issues. They couldn't aspirate from NGT, so they were very anxious, and they called our nurse, who did a home visit, checked the NG tube. It was actually patent, and we reinforced the CGT for the NG tube. There was also an episode of a mild infection in early July where she had persistent fever with some respiratory symptoms, and she was started on a course of oral Augmentin by our CHT physician, which led to resolution of the infection, and the fever resolved after that. You can also see that there are multiple visits done by our physiotherapists as well as our occupational therapists. So our physiotherapist did CGT for bed exercises, chest physio, as well as suctioning. And our occupational therapist reviewed bed-bound care and transfer techniques, and also did showering CGT. You can also see that there are multiple telephonic reviews done during this period of time, just to reinforce some of the education that we have done to the caregiver, and also resolve some of these acute crises that they had at home. And of course, on the background of all of these, we had constant case discussions in our multidisciplinary team on how to best care for Madam Lim at home. So we achieved several milestones in this about 2 months that we have, actually 2 months plus that we have been holding this case. We improved caregivers' competence as well as confidence. So now the caregivers are quite confident in the NG tube feeding and troubleshooting, tracheostomy care, suctioning, as well as IDC care. We managed to treat an episode of infection at home and kept her in the community. We also improved mobility for Madam Lim. So now she's able to sit out of bed every day. She's able to take showers regularly, and she is even able to take outings to the community. So I show over here some photos the family took when they went out on an outing to Gardens by the Bay. And once again, this is what we call a hospital win, right? So the patient actually stayed out for 2 months this time. And she was referred in again because the St. Luke's nurse, so a comm partner that we had referred to just for procedures for changing the IDC, had difficulty changing the IDC. So she came in and she was admitted for 3 days, a fairly short stay compared to her previous admissions for catheter-associated UTI. Actually, Madam Lim is currently still under our care, and we are still having some ongoing interventions, some of which include, we are trying to transit her from IDC to IMC, and this is after discussion with the urologist, and we hope to reduce the risk of her catheter-associated UTIs, for which she has had several episodes this year alone requiring admissions. We are also in the discussion about long-term care. CHT in its nature is transitional in nature, so we can't hold on to this case for too long. So we are still trying to look for an appropriate community partner whom we can hand over this case to. And lastly, we have also referred Madam Lim to the ST for swallowing, as well as augmentative and alternative communication. So Madam Lim actually isn't able to move her limbs very much, but she can still move her eyes and blink. So this is one of my last few slides. On the right, you see several photos. This is actually Madam Lim's son's wedding earlier this year, earlier this month. And what you will notice is she doesn't have an NG tube in this photo. Yeah. This was something that was important to her. She told us that she would like to go to her son's wedding without the NG tube, and she would like to appear in the photos without the NG tube. So we tried to help her achieve that. We timed her feeds as well as her medications such that the NG tube could be removed just before the son's wedding, and after she goes back home at night, we arranged for the NG tube to be reinserted and her feeds recommenced. And we also gave the family confidence that this can be done and not to worry. So this is what Mr. Raymond Tan had to say about his experience with the CHT so far in these few months. So the transitional home team has been instrumental in providing valuable information and advice so that we can continue care and treatment from home. Absent that knowledge and reassurance, and given Mui Hia's chronic condition and susceptibility to infections that can be life-threatening, our first instinct is to send her to the emergency room. This is especially so given March 10th experience. With proper treatment advice and caregivers training, we can give Mui Hia a comfortable and safe environment at home without undue worry. So just some brief takeaway points. So for the appropriate profile of patients, patients with complex needs, the community health team can reduce hospitalizations. So once again, hospital win with caregiver training, education and treatment of mild illnesses at home. This often involves a multidisciplinary team approach with very timely, regular follow-ups, as you could see from the chart earlier. And we can also play a very meaningful role in enabling our patients to stay in the community and achieve what they want to do in the community. And so this is, in what ways, in some ways we will see this as maybe a patient win. I just need to give special thanks to Madam Lim, Mr. Raymond Tan and their family for allowing me to share their story, their photos, and for Mr. Raymond for giving his perspectives on what has happened so far in the last few months. And I especially would like to thank the CHT team who has managed this patient, Sister Tina, Dr. Loh, and our allied health colleagues, Marianne, Narisha, and Shi Hui. Thank you.